prevention and the aging. So let's welcome Dr. McFall.
Thank you very much. Is this coming through on the microphone? Is it coming through on the microphone? No.
It's not.
I've learned a little bit about the demographics of your group. Dental hygienists, social workers, you're a social worker, physician assistant students, nurses, everybody else. All right. Well, in thinking about health promotion and disease prevention, I also think about demographics and the change in the population, because in public health we think about population trends. And at this point you probably know all about it, but we have a large increase coming up, has been coming up and will continue to be coming up in people who are 65 or older, and especially the group that's 85 or older. We also know that with that population mix is going to be an increasing number and proportion of people who are Hispanic, African American, Asian, etc. In thinking about the health, the broad-based health of older people, we know that the mix of chronic diseases have got a major impact on functional limitations, that is, not being able to do the things that they want to do, and in disability, not being able to fulfill their social roles. Okay? And these are some of the major chronic conditions that influence functional limitations, disabilities, and as we'll see, mortality. Okay, so these are the background upon which we're dealing with when we talk about older people. Now, the bright spot for me, and for most of us dealing with the elderly, is that the disability rates have been declining. So starting back, I worked with this National Long-Term Care Survey, which is the source of this very important information, going back to the 1980s. And at that point, 25% of older people were disabled in terms of having one or more instrumental activity of daily living, one or more activity of daily living, or being actually shut up in an institution, you know, a nursing home, something like that. Well, 15 years later, it's down to, there's a 5% decrease. And when you think about the millions of people that we're talking about, a 5% increase is a rather heartening thing. It's actually one of the first, and this is circulated with detailed, we can look at individual indicators and see the same sort of encouraging trends on many fronts in relation to trends in disability. Okay, so that's the bright side. We've got the big wave of older people. We've got the press of chronic conditions that cause us to have limitations, but we've got some heartening trends also. So what I'm going to be talking about today is disease prevention and health promotion. I'm going to talk about disease prevention first, which is trying to keep healthy or asymptomatic people from getting sick or experiencing the bad effects of being sick. And the levels of prevention that we talk about are primary prevention, where we're trying to decrease the probability of disease or dysfunction. You might think about mechanisms to do that, like smoking cessation, dietary changes, immunizations. Those are all primary prevention mechanisms. Secondary prevention is trying to identify disease in its early stages, cancer screening. On the clinical front, it might be trying to identify changes that are subclinical before they have clear clinical manifestations. And tertiary prevention, where you're trying to restore function. Cardiac rehab would be an example of that. Many of our medical treatments are examples of that. Tons of things that people in physical and occupational therapy deal with are in this realm. And I'm going to be talking about, as a particular example, an intervention, health promotion intervention for urinary incontinence, which falls into this tertiary prevention realm also. Now, in our country, one of the most unusual trends in public health has been that we've started working to objectives. And that started in the 1990s, and it goes along with what's happening internationally, where the whole global health community is also working on toward objectives. And the most recent one is the Healthy People 2010. This results from a collaborative process to set our national health objectives. Some of you may have been involved, or your teachers have been involved in this objective setting project. 67 of the now 467 objectives are specific to aging. And just on your own time, you can search them. You can see how your particular pet area, what objectives are set up in there. This is our score-keeping system. And we find, like in sports, that we win more when we have a score-keeping system. How are we doing? Here's some areas where we've got data from the Behavioral Risk Factor Surveillance Survey about what our target is, how we're doing with respect to U.S. seniors, people 65 and above, and how we're doing in Texas. And you can see that Texas is not that different on these behaviors. You know, all Texas seniors are not that different from all U.S. seniors. But we're not, nationally and in our state, we're not doing that well with our targets about leisure activity and obesity. But we have exceeded the target for current smoking in our particular state. All right. Then these are what we call clinical preventive services. We can see that, again, Texas as a whole is quite a lot like the rest of the nation for senior citizens, and but that we're nationally and in our state not doing very, very well with our targets for adult immunizations, and exceeding our targets with respect to some of these cancer screening behaviors. You'll note that the target set for colorectal cancer screening is pretty low. And what that means is that the next time there's a process of setting objectives, we'll ratchet that up so that we can help to improve the health with respect to this very common and deadly cancer. Okay. Now, we talk about Medicare. It's the primary source of health insurance for the elderly. It's usually spoken of as an acute care-oriented healthcare system. We'll be looking at a few of the preventive services that are paid for by Medicare. And I think an interesting thing about it to note is that Congress has led this program to most of these preventive services rather than the program asking to cover these. So they've kind of been pushed into offering some of these. And we now have sort of a pretty good package. And I put in a lot of slides about this. I'm not going to talk about them all, but you'll have a reference. You'll be able to go back and look at this. This could be particularly relevant to the PA students who would be in a position of doing more billing and things like that. But also people that can do encouraging. You know, it's a lot easier to encourage people if the access barrier has been removed. Okay. This is a summary, and I'm going to talk about 4 of these, but this is the whole range of the summary of preventive benefits under Medicare. This one is pretty new, the initial preventive physical examination. They call it the Welcome to Medicare visit. So you get this once in your lifetime. in your first 6 months of being on Medicare. Its purpose is to channel beneficiaries into other preventive services, so to do initial assessment and to get people the help that they need. So the components of it are to take a history, to take at least one time in the person's lives a look at whether they're depressed. You know, if you don't ever do it any other time in their lives, at least do it when they turn 65 and go on Medicare. To check their functional abilities and ask about their house safety, things like that. Do normal sorts of height, weight, blood pressure, visual acuity screening. Do a heart examination, and to do education, counseling, and referral based on all these things, and to give people a written plan. I mean, I think that's very important to close that feedback loop with the written plan. So this is brand new, and there might be some medical professionals who aren't aware of this. There certainly might be people who interact with medical professionals who are not aware of this.
Who actually came up with it?
Who came up with it? I don't know. I don't know who came up with it. My guess would be that the Congress suggested to CMS, the Medicare funding organization, that they have something like this. Okay, now talk about a little bit about cancer screening, which is an area that I work in. I work about informed decision making about prostate cancer screening, but there are Medicare pays for particular categories of people, and you can see that on your slides. Screening for breast cancer, for cervical cancer, for prostate cancer, and for colorectal cancer. And the details vary, and you can see that on your slide. They'll also pay for other screenings. Screenings for glaucoma. We know that a lot of disability comes from sensory impairments, and the glaucoma is a major source of visual impairments. But this benefit also covers cardiovascular screening every 5 years, diabetes screening. We'll look at that one because that's a big one for, I did a hide on it. Does it show through on your slides though? Okay, so in the diabetes screening, if you've got a risk factor of hypertension, dyslipidemia, obesity, you've had a previous elevated impaired fasting glucose level or glucose intolerance, you're eligible for the diabetes screening. If you've got two of the following: overweight, family history, being old, or a history of gestational diabetes mellitus or delivery of a baby over 9 pounds, you're also eligible for this. So in our city, where we are concerned about diabetes, the diabetes screening mechanism is a very useful one for that segment of the population that's over 65. Medicare also pays for a variety of services for people who have been diagnosed with diabetes. That includes self-management training. You can get equipment and supplies. You can get shoes. You can get dietary counseling. They call it medical nutritional therapy. Oh, you know all about that, right? That's dental hygienists, not dietetic people. Sorry. And I know lots of people don't know about the smoking cessation counseling benefit. So people with Medicare who use tobacco and have an illness caused or complicated by tobacco use, and that's quite a range of things that you can count in there, can get up to 8 visits a year over your short-term counseling or your long-term counseling. Okay, questions here about our prevention area? Okay. Then, prevention, health promotion, people think they sound a lot alike, and they are a lot alike. But there's some interesting differences. The WHO and the Ottawa Charter for Health Promotion defined health promotion as the process of enabling people to increase control over and to improve their health. So you can see that there are a lot of preventive angles that may not be initially, they're not always things that are trying to help people have control over their health and to improve their own health. So I think that self-determination area is something that's interesting to us health professionals and worth thinking about every now and then. You know, write it on an index card and stick it up in your well, everybody's got these electronic planners now, but I've got a little black book. Now, in health promotion, which is actually my division in school public health, we are guided by an ecological framework where we say that the health of individuals is guided by influences taking place at multiple levels of the environment. So we've got the inside the body environment where we have things like our skills, our knowledge, our motivations, our attitudes and beliefs, you know, all of those things that are personal to us. We have our social ties, influences occurring at the interpersonal level, where we've got things like social support and having access to information. Do you know somebody that you can ask about something about health? That's a social tie influence. We have influences at organizational levels. And we have influences at the community and policy level. So thinking about this in relation to trying to encourage elderly women to get breast cancer screening, for example, we would think about, does that individual have the knowledge and beliefs that this will be effective for them? Okay, that would be at the individual level. At the social ties level, does that person have a buddy or encouragement from someone that they care about that says that they should go get breast cancer screening, or that would give them a lift to go get breast cancer screening, things of that sort. At the organizational level, within our healthcare system, are the physicians or other healthcare providers, PAs, geared to recommend this? Okay? And at the community and policy level, we want to address barriers that may exist. And that might include public education, that might include public transportation, it might include, in some locations, having changes in the service configuration in a particular community so that there is access to that type of service. And at the policy level, we've seen that it has been addressed by Medicare by removing, I mean, not only is it covered, but it's covered and there's no copay. You know, so that's an important policy consideration. Okay. So, I'm going to be talking about a particular example of a health promotion program that I was involved with in Oklahoma, when I worked in Oklahoma. And this is a community demonstration project on urinary incontinence in older women. And we're going to look at this in terms of what it tells us for some of the important aspects of health promotion. And so when I go through it, I'm not just talking about it because we care about urinary incontinence per se, although we do, but because of what it tells us about health promotion. So, whoops, falling behind here. This was a collaborative project, and often in health promotion, if you're talking about working on multiple levels you are going to be talking about collaboration, because which of us has got the expertise to deal with influences taking place from the individual to the policy level? I mean, really, that would be the Renaissance woman, right? So this was a project. It was funded by the Centers for Disease Control to the Oklahoma State Department of Health. It was CDC's first foray into chronic conditions that don't kill you but might make you wish you were dead. You know, it's along the lines of adding life to years, not adding years to life, okay? And I was with the College of Public Health, and I was the chief, scientific and health promotion person. And the Geriatric Education Center, which is like the Geriatric Education Center here, only it's in Oklahoma, did a lot of the professional education work. And we had a coalition of senior advocates, professional societies, and service organizations that worked with us to make sure that our intervention fit well with the community and fit well with the population that we were dealing with. Okay? So that's important, that you might have to work with other people to do health promotion. Some background on urinary incontinence. Prevalence estimates are all over the place. At the time we were working on it, we thought it was around 15 to 30% in community dwelling older persons. And when we did our needs assessment, a telephone survey in Oklahoma, we found 34%. But we had to ask the question, do you have involuntary loss of urine? Yes, no, and we had to add a category, a little bit. So combining the people who said yes and the people who said a little bit, they were 17% each, okay? This condition is associated by aging-related changes and by comorbid conditions, great range of things from neurological changes, changes in the structure of organs in the urinary system, mobility issues can influence this great range of things that we're not going to go into today. But less than half of the people who have this condition seek treatment, despite the fact that there's a broad range of effective treatments. There are effective surgical treatments, there are effective drug treatments, there are effective behavioral treatments. And in our area, we decided that we were going to do a behavioral treatment, to test behavioral methods, to test things that were sort of related to self-management and self-help, but with a little bit of assistance. So not high tech, not high levels of advanced, not highly sophisticated medical issues. We're going to deal with therapies that had proven efficacy, and here we're talking about the pelvic muscle exercise, or you might have heard it talked about Kegels, and we used bladder retraining, self-regulatory method. We had small groups of participants who would participate in this educational and social support group. We did it every other week over 5 sessions. And there's a method to that madness. It's not that it took that long to learn the materials that we were teaching it. You know, I could teach it to you in, 45 minutes. But it takes that long for the behavioral change to take place. So if you have a session, take 2 weeks off, you have another session, take 2 weeks off, you have another session, and you practice your skills all in between, you have time to develop the skills that will help you to change your behavior, okay? So it's not always what it takes for us to deliver it, but it's what it takes for our clients to absorb and make the changes. Now, we're talking about now the health promotion, this health promotion intervention in relation to what's going on in the ecological model. So at the individual level, what we we were using social cognitive theory. Has anybody heard of social cognitive theory? Okay. So this is a psychological theory developed by Albert Bandura, who says that we have the person, we've got the behavior, we've got the environment, and that these are interrelated. So thinking about walking. If I get motivated to walk and I start walking, I buy my shoes, I get up early, and I start walking. So that's the person. Then I got the behavior, that's the walking. And then we've got the environment. So if I get up early and I put on my shoes and I go walking, that changes me, changes my behavior. People see me out walking, so I become part of their environment. So when we see more and more people out walking, that changes the person. Because the person says, wow, this is really great stuff. I'm like everybody else, I'm walking. So the person, behavior, and the environment, social cognitive theory. Social influences, cognitive influences, what's in our brain, and environmental influences. Okay, so at the individual level, we were helping people to learn how to cope with their urinary incontinence. We were giving them skills for dealing with their urinary incontinence, how to do those exercises. Oh, by the way, we learned from our participants, they said, we started talking about pelvic floor exercises, because they talked about bringing up the pelvic floor. And they said, oh, honey, I can't get down on the floor. So we learned to call them pelvic muscle exercises, and that sounded more like something you were supposed to exercise your muscles. That's how we learn from them. Self-efficacy, as you start to have initial successes, you have more successes because you feel more efficacious about this. And self-regulatory behaviors, using diaries and methods like that, where we're actually checking our behaviors against it. Okay. The interpersonal level, we had the small group. There was a great deal of social support shared in these small groups, which were around 6 to 10 people. And some of these people had never had a chance to actually talk about their problems, and they found this very reinforcing to be able to talk to other people and get ideas from them and things like that. They also got reinforcement and guidance from the facilitators of the group. So that's at the interpersonal level. The organizational level, we were working with existing health agencies, hospitals, a senior continuous care retirement center, one other group that did a lot of health education. So we worked within existing agencies so that there would be a chance that these interventions could be carried through in the future with these trained individuals. We used a train the trainer strategy where we trained personnels that worked, really. We trained people that worked in those staff how to do the intervention. And then we also disseminated the intervention package to the larger professional community. We had requests coming from all over the country for this program. Okay. At the community level, at the community and policy level, we did not work at that level. And that would potentially strengthen it. But there are important policy changes that could address this particular public health problem. Like, we know, for example, that in the town of San Antonio, they're thinking about the presence or lack of presence of public restrooms in the downtown area, down around the Riverwalk and in the larger city. So having public restrooms could be very helpful to people who are restricting their interaction because they don't like going where they don't know where every bathroom is. And I've talked to women who tell me that they know every bathroom in North Star Mall. Every bathroom in Ingram Square Mall, whatever. There could also be room for policy changes in terms of benefit packages with respect to Medicaid. A lot of elderly services are paid through Medicaid. And in Pennsylvania, because of how the state structures their program, their home health patients get services for urinary incontinence, and in Texas, we do not, okay? So there is room for policy elements here. This is some background about our participants. They were a pretty white, pretty well-educated group. They've had urinary incontinence for quite a while, and they think that it's a problem. You know, they're doing this because they think it's a problem. This is our conclusion. This was a randomized controlled trial. So this is a high-quality scientific study with good confidence in that when we say that the effect is associated with the intervention, that the effect is associated with the intervention and not with other characteristics like the characteristics of the participants. Okay, so comparing our intervention group saw a substantial decrease in the average number of incontinent episodes per week relative to the control group. Okay? This is a significant finding. This is a bit different way to look at it in terms of the cumulative percent improvement. So if we look at the intervention group, 60% of them had at least 50% improvement in their number of episodes. As a social scientist, I don't just care about how many times women have incontinent episodes or wet their pants. I care about how it affects their lives and roles. And so this is a measure of the number of aspects of their lives that they said that incontinence impacted upon before the intervention and after the intervention. And so major decrease in the number of areas of their lives, like relationships with their husbands, sex, being able to go out, you know, a great variety of role-related activities. Major decrease in the impact of incontinence. And this decrease is not significant for the control group. Now, there are other, that's a condition-specific type of impact measure in terms of, but there are other types of measures. So this would be like a general across-the-board quality of life measure. It's from the medical outcome study. You may have heard of the MOS 36 or the MOS 12 or whatever. We don't see a decrease in this. And I showed you just a couple of them. Like, these are the ones that I thought we had the biggest shot at influencing. Level of energy, I thought, you know, if we could get these people staying in their beds more at night, they might feel like they had more energy. But it didn't work out. And the mental health, we didn't see a decrease in that either, although this group did not complain of having depression or anxiety, so we didn't see too much of that anyway. So summary about this particular public health intervention. We developed a public health model for incontinence. We showed a significant effect on incontinence episodes and reduced the impact of urinary incontinence on role functioning. No effect on global quality of life. In thinking about the qualities of that intervention, we involved numerous community organizations and different types of professions in working on this particular area. We learned a lot about working with one another. We learned a lot about ideas of self-regulation and making personal goals to improve your health. I think that's some of the things that I learned from doing this intervention. Now, if we think about this whole topic of health promotion and disease prevention, there's some take-home points I'd like to bring to you. And that nationally, our goals are, especially for seniors, elderly persons, to add life to years, not to add years to life. That health promotion and disease prevention are an important component of that. We want to see across the board in our health professions an increased emphasis on prevention and health promotion so that we can promote independence and vitality in our older population. We want to emphasize the importance of broad collaboration in health promotion so that we are addressing health at multiple levels. Maybe you work primarily at the individual level, but you might be drawn in to work in a community coalition. For example, I worked on a community coalition about adult immunizations. I don't give a single shot. I'm a sociologist, you know. I don't give a single shot. But I can work with organizations about how to help organize their rollout process in the fall and things of that sort. So you may be called on to provide expertise to people who work at an entirely different level than what you work at. And finally, I'd like us to make every profession a health promoting profession, where we are helping people to make decisions about how they want to improve their health and what they want to be doing to have more control over their health at the individual and at the community level. Okay, that's it. Thank you. Do you have any questions?